Good evening, everyone. We're not getting started just yet. I just wanted to do a bit of a sound check before we get started. So if you can hear me, can you please just type yes into your questions box? Thank you. Perfect. Already getting a few yeses coming through. Thank you for that. Good evening, everyone, and thank you all for joining us this evening for the New South Wales COVID-19 update webinar. My name is Beth, and I am joined tonight by our panel from the RACGP, New South Wales Ministry of Health and AMA. We have Dr. Charlotte Hespy, Dr. Penny Burns, Dr. Kerry Chan, and Dr. Danielle McMullen with us tonight. So firstly, I would just like to do an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work. We pay our respects to elders past and present. I'm just going to quickly pass you over to Charlotte Hespy.
Hi and good evening and welcome. I just wanted to start the evening by formally acknowledging the death yesterday, well it was actually Sunday night, of Harry Nespolon. As all of you would probably know, Harry was president for the RACGP and his term was not actually due to finish until November of this year. Tragically, Harry was diagnosed with pancreatic cancer in October last year, and despite a valiant battle, that nasty beast got him pretty quickly in the end, and so it was a relief for his family that he did pass peacefully on Sunday. For me, I've lost a very dear long-term friend, but more than that, I think we've lost a passionate and inspiring leader of general practice. He, I think, was an example of how to lead. He didn't do it on his own, he did it collaboratively, but he did it with a strong voice, and he was never willing to stand down for those things that he truly believed in for general practice. And he very much was our advocate at all levels of government. And he put in an amazing amount of time, and that was despite his illness. He was working fearlessly for the RACGP every day of his life until he actually died. And so I'd like to personally thank him for that. And the challenge for us now is to take up that mantle and continue the powerful work that he's achieved over the last 18 months. Thanks, and I'll hand over to Kerry on that sombre note.
Yeah, thank you, and I feel the grief in the GP community for the loss of such a great leader. So in terms of where we are on COVID, I suppose if I want to just describe the fact that New South Wales has encountered a number of seeding events from Victoria, and that's led to a number of outbreaks. And at the moment, we are trying to contain those outbreaks. And to contain those outbreaks require the actions of the community to come forward for testing, requires the community to also change their behaviours and practice more social distancing, hand hygiene, limit their gatherings, requires business to step up and increase the COVID safety of the measures that they've put in place. And I think GPs play a key part in that, in talking to your patients around the importance of coming forward for testing, particularly over the next 3 to 4 weeks. It's likely we'll be putting out spot fires across the state. And to be perfectly frank, it's a little bit of a roller coaster. So what I'm particularly looking for is high rates of testing and then the fact that when we're getting cases, they're occurring in households of people that we have already identified as a case, or people that are close contacts, and we've already got them in isolation when their diagnosis is happening, so that we can be confident those chains of transmission have been broken. We clearly have had some new, we've announced the Thai Rocket Potts Point, and we've also announced the Apollo restaurant. And we are looking obviously at linkages between those, and we think we've found some linkages that explain that. But what also concerns me is the clusters that we haven't seen. So overall, I think the Bateman's Bay cluster is closed down, and that's thank you to the community, including the GPs who tested so many people in that community. The feedback across ACT Health and our own health services is that the community responded. I'm happy that that is basically closed off. We've had also similarly a magnificent response in Port Stephens in relation to some seeding from the Thai Rock cluster in there. And in Ballina, we've had similarly some high rates of testing when there was a returning Victorian. Whilst we have border closures in place, no border closures are perfect because people have to move around for critical services. So there was always the risk that people are coming in. And we also have to reinforce patients and community members continuing to do the right thing. So people that are returning from Victoria are required to self-isolate. And again, if you'll raise that with you, or people are concerned, please notify your public health unit if you think that people are not complying. It's so critical for us to have high degrees of compliance. The ongoing threat of seeding from Victoria remains. At the moment, the disease is still predominantly in the areas around Mitchell Shire and also in Greater Metropolitan Melbourne, but there has been some move outside to regional Victoria, particularly in some of the adjacent sort of along the Great Ocean Road sort of suburbs. Victoria Health has a great map. If you go to the New South Victorian website, it says for more information. If you'll click through that, on about slide 4, it actually has information on notifications from the rural regional, and we might circulate that link. So for those GPs that are on border communities or interested in activity, that might inform your risk assessments or your advice about your patients that may be travelling for care in Victoria, or that may have returned. I will circulate that website. We're also going to be assisting Victoria in doing the contact tracing around the border communities, which also will give us some early intelligence about risks that might be posed to our border communities, which is quite a long border and inextricably linked. So I'll probably leave it there and take questions, Charlotte.
Thanks, Kerry. I might lead off with the sort of the topic of the week, I suppose, which has been around masks. So there's a lot of curiosity amongst GPs around how they sort of, I suppose, set up their protocols, in particular about patients being recommended for masks as well as GPs, and any other recommendations that you might have in terms of how general practice might structure the whole recommendation of wearing masks as a healthcare worker.
So with the risk of community transmission, particularly in those areas of southwestern Sydney, western Sydney, and as I said, it can quickly change. We've been very conscious of, from a health perspective, or New South Wales Health, taking a universal approach to upping our level of protection that we're advising our staff to wear, and that reflects that staff move across, so it's easier to have consistency in application. So we are recommending that patients, particularly those in ED, are affixed masks, and that staff are wearing surgical masks. We're also very much messaging that it's we know a lot of the healthcare worker transmissions has actually occurred from the social behaviours in the tea room, at the smoke, where cigarettes, not that we encourage cigarette smoking, but at those times when people cluster. And so they might have these perfect behaviours of infection control, but then when they go and do those more social activities associated with lunch break or other breaks, they lapse into those social behaviours, which we're all drawn to, which is getting closer than the 1.5, and potentially at that point not wearing our surgical masks. So we're also very much encouraging those behaviour changes to be embedded, as well as we sort of, I suppose, get prepared should we see increased community transmission. We've also taken steps to increase protections for aged care. The experience in Victoria has been that generally the disease has been introduced into aged care facilities through staff. That's because staff are critical workers. It's important that, you know, we do need staff in aged care facilities. And so Victoria has moved to universal surgical mask wearing in aged care facilities. We've written out to aged care facilities across the state and recommended those settings for the areas where we've had any concerns around community transmission. And again, the premise of that is to try and stop the COVID from getting into the aged care facilities. And we've also recommended blocking people from attending or reducing visitor numbers in those aged care facilities, or ensuring that people were not having any visitors in those areas where we were worried about community transmission. So I suppose for your own practices, it's really a case-by-case assessment, but that's what we're doing in the health system. And I suppose it really depends on the caseload, the type of nature of your patients, but certainly we see the importance of weeding out those patients that have respiratory symptoms or any symptoms. And we also think that obviously healthcare workers at a time need to protect them, you know, take a bit more caution in protecting themselves, because we probably have some undetected transmission going. The risk profile is higher now than it probably was 4 to 5 weeks ago, when at that point we had very minimal, if any, community transmission occurring.
Thanks, Kerry. I'll let Penny and Danielle have a go in a minute, but can I just, there's a really interesting question or statement here around one of the doctors is posing that he suggests maybe there's more benefit in having more people wearing masks than social distancing, and that if we actually increase the use of masks, then we might actually do more than continuing to talk about social distancing. I mean, that's certainly not been what I've been saying to people. So can you make a comment about that?
So I think we are very much messaging about the 4 elements of protection. So the first, and I think it's important that we message them equally. And first of all, don't encourage people to get out and about with coughs and colds, because from our investigation of outbreaks, many people did actually have symptoms when they were in those places. So it's not the time to go into, you know, don't go to the restaurants, don't go to the cafes when you've got those symptoms. It's not the point for social gatherings. The next one is clearly, you know, good hand hygiene, social distancing, but we really are up messaging the role of masks. But it's probably what's really important is the greatest risk in the role of masks is probably in indoor settings, not necessarily outdoor settings where you can socially distance. So from our experience, it is in those hospitality settings, pubs, clubs, places of worship, public transport, where we need to up mask wearing. So where you can't socially distance and where it's indoors, that's where the greatest risk of transmission is. And so why we need all the strategies is because we know that a lot of transmissions occur in household or family or social gatherings. So we also need to message that you're more likely to be infected by the person in your social network than by walking past someone in the street. And so we do need to get people to be aware of that, because there is a perception that people that you know are safe and you're going to somehow get COVID from others. So like all things in health, there's no silver bullet. And I think we need to use all the strategies, but certainly messaging around the use of masks in those settings, particularly focusing on indoor settings as things get busier, as people move about more. It's a critical protection we need to add to our toolbox and really strengthen our messaging about.
Thanks.
Look, thanks, Kerry. I think that's a really important issue for GPs at the moment, is whether, I know I work in a general practice that's actually co-located in a hospital, and the advice from the hospitals come through that staff are to wear a mask whenever in close proximity with patients, even if for less than 15 minutes, especially when examining them. And I guess in our general practice, we've not worn masks unless we've tried to filter out those with respiratory conditions. We've done the social distancing, and we've only worn masks in particular selected patients. And we've just in the last couple of days decided to go to wearing masks for the GPs and the nursing staff. And that's a decision we've made. And we stream anyone with respiratory conditions through the back door into another area. Can you comment a little bit further on the wearing of patients wearing masks? So in Victoria, of course, they're asking patients to wear, in these affected areas, to wear masks if they're over 12 years of age, if they've got a medical condition, if they're doing strenuous exercise, if they have, there's an issue with being deaf or hard of hearing and they need to see that. And I guess also the other thing I was interested in is people's sort of refusal to do that sort of thing, and what your thoughts were on that.
I think we have to be very supportive of people wearing masks. So for me, there's still some pushback that our community probably isn't as au fait with mask wearing. So I think that's a key role that GPs can play in normalising it. And in essence, when people are wearing masks, they're actually protecting you. So the principal basis for a surgical mask protecting others is you're protecting should you have it and be in a pre-asymptomatic, whatever you want to call it, period. That's the purpose, principal purpose of the mask. So therefore, I think we do need to explain that to people, and also say that that's a positive thing if people are taking those behaviours, and not see them as a threat or a risk. And I think that we can certainly encourage the wearing of masks more than we have. You know, I think it's going to be part of our toolbox in the response to COVID. But as I said, I think messaging it, particularly in some of those indoor environments, which we know are associated with greater COVID transmission risk, is going to be really important.
And I guess the other question, before I let Danielle ask a question, is around the reusable masks. If there's any sort of information around how useful they are, or how protective they are.
So what I might do is circulate to you some advice from ICEG, which is the National Infection Control Committee that provides advice to AHPCC. There's some, clearly the evidence is stronger for surgical masks. The evidence isn't, great, but it would make rational sense that masks of any sort do block out droplets and therefore would have effect. So there is support for wearing reusable masks, but there's specific requirements around it being 3 layers and made of different material and breathable. And so I'll circulate the ICEG advice, because again, I think that's a really good advice, that if patients are choosing to use the masks, and as I said, I think we should really encourage that as a positive contribution, then at least you can advise them on the sorts of masks that are going to have the highest likelihood that are going to be effective. Yeah.
Fantastic.
Thanks, Kerry. And I think that'll be helpful for people, because we are seeing a lot of if the question is that all GPs should be wearing masks with all patients, on the private market, masks are still a little bit tricky to get a hold of. So people are trying to be also environmentally aware when possible. And I suppose I would echo Penny's statements before, that our practice has done a similar thing of encouraging our doctors and other healthcare staff to be wearing masks when they can't be more than 1.5 metres away from patients, so particularly for examination things. And while the New South Wales Health Protocol and the RACGP has said the same thing, while New South Wales health advice doesn't strictly apply to general practice, we're encouraging private practices to follow similar advice where it makes sense to do so. The question, I suppose, we'll probably come back to masks, I'm sure, but to give everyone a little break from mask things, you raised before the idea of people not going to cafes and restaurants and things when they have symptoms. The advice at the moment is that people with symptoms should be staying home. We've had a couple of questions about whether that applies to everyone even after they've been tested. So if people have very minor earthy symptoms and they've had a negative COVID test, are they still stuck at home until they're completely symptom free, or sort of what's your guidance around that?
Look, this is a tricky balance because we don't want to put too many disincentives for people getting COVID, but it's pleasing to see how effective we've been at dampening down flu and some other respiratory viruses. So probably people do actually get out and about a bit too much when they've got respiratory symptoms, and it might be the time to, you know, wait a couple of days before going out to the restaurant. This is a fine balance because we don't want to dissuade your patient. So to some extent, I'm not going to give you a perfect solution to this, but clearly I think we should be messaging that, you know, other respiratory viruses, you know, can have consequences, are not pleasant for everyone. And maybe we also say, you know, that's not, even if you've got a negative COVID, please don't visit aged care, disability, or some really vulnerable settings. And wherever possible, you know, it may be prudent just not to go to that big, you know, family gathering where, you know, you're going to be hugging and kissing everyone at that event. So I suppose it's just I just sort of say, you know your patients best. We're trying to balance putting them off getting a test. We want them to keep engaging with you, so we don't want you to tell them things that are too scary, but we do, you know, I do think it's reasonable to have a discussion that other respiratory viruses are not desirable to be sharing around either.
I think what we've been telling people too is that if you've got symptoms and you need to go out for whatever reason to get a test or to get shopping and things, that those people should be wearing masks when, if you do have to be out of the house with symptoms, be sure to be wearing a mask.
That's right. That's correct. And I think that's a classic example of where masks are a no-brainer, that we need to really reinforce that behaviour. And maybe everyone needs, with the thermometer, some reusable masks or some surgical masks.
I think it's a really good opportunity to sort of rethink how we think about respiratory symptoms anyway, and the sorts of behaviours that we have. I sort of liken it to when I was an intern, we were just emerging into an environment of having to wear gloves to put in IVs. So I learnt everything I did was wearing gloves, but my registrars had learnt with bare hands. And it was a really interesting time where they were struggling with changing over to this concept of all protection for blood products, and also the idea that we needed to treat every single patient in the same way, that is, that they had contaminated blood, even if we felt that they didn't, that they still got treated. The blood was treated with respect. And I think in the same way, we need to now be treating with respect the whole idea of the respiratory tract infection, that it may possibly, any of these mild symptoms may possibly be COVID. It could be flu as well, but either way, it's an illness that can cause significant symptoms for people and be transmitted easily, and therefore we need to actually rethink and the way in which we interact with people with those symptoms. And it's the same thing. There's a question there about why do all GPs be recommended to wear masks? We're not saying all GPs are recommended. We're saying that you have the choice to do what you do, but being mindful, exactly as Kerry said, about where you are. It may be more important that you do it for every patient every single bit of the time. And that's not a bad overall concept, because then you don't have to actually think about it. It just becomes routine that everybody's got a mask on. Because for me, it's that grey area when you don't know that there's people coming in and you're then not behaving in a way that's respecting that particular form of being able to transmit. Whereas if we just made it, this is what we're doing, it's not actually discriminating, it's not anything, it's just a safe way of protection.
One of the things I've been really horrified about working in a respiratory clinic is I only realised, and I was in shock almost the other day, I had a patient that I was talking to about how they were getting home because I was considering what I needed to do with them. And she came in an Uber and she was going home in an Uber. And then I started asking patients, and there are huge numbers of patients presenting to the respiratory clinic to be swabbed and then wandering off in public transport and other means of transport. And then other people have sort of been saying, oh yeah, and then I saw my friends doing the, wandering through. I think the message about what they need to do after they've been swabbed is probably needs to be reinforced and isn't getting out there. But one of the groups we've been seeing in the last few weeks is we've been seeing a number of young parents who want to get back to work who can't because their child has a lingering cough or has a lingering respiratory infection. And I sort of did more mental health counselling rather than swabbing for some of these parents. And then, of course, there's the parents who don't want to have their child tested. They're happy to have themselves tested, but they don't have their child tested. And so there's that sort of refusal to have a test sometimes. And some of the questions that are coming through are saying, what should we be doing if someone refuses to have a test and has suspected symptoms?
Look, I think there's no one answer to that. So I think it's very different if they're a contact of a known case, if there's particular things that concern you about why that diagnosis will be critically important. So for instance, if it was like an aged care worker or a disability worker, then the GP would obviously be very concerned if you thought it could be COVID and they're not getting a test, because that's counter to what we want. And also it means that they could have been at that facility. So not all tests of the same ilk in terms of the implications for either the community and the broader spread. So that's a consideration. There's also a consideration for the implications of other people in the household. So again, you may be the family doctor and be aware that there's other immunocompromised or other vulnerables, and where that diagnosis would actually, again, have a broader implication for that family. And then I suppose just as you do work through with all of your patients, understanding why they don't want to test, what is the barrier to it? Is because they haven't got, they're worried that they have to be off work, or worried about, what it means for them, or they're worried that their privacy will be breached. I suppose just unpacking those elements of it. And, in those circumstances, if there is extremes and those sort of things, health can, find accommodation for people that may not be able to self-isolate at home, or we can look at other, areas of compassion that can help remove some of those barriers. So we probably do want to get some feedback from you about what do you perceive the barriers to be, but clearly the implications for a patient declining will be different depending on their individual context.
Thanks, Kerry.
There was a comment about some people don't have private transport, which was again that Penny. I mean, certainly in my area, a lot of patients don't have private transport, and so it's been quite a conversation about. Often it's trying to negotiate with somebody how they're going to get to the testing and then how they're going to get home again, and what is deemed safe and what's okay. So I wouldn't mind a comment from you, Kerry, too. I mean, in terms of, I know the advice I've been giving to some of my more sort of vulnerable patients who really can't get to testing except with, with not private transport, and they're getting home again.
So obviously private transport and being transported, sitting in the back of the car with the windows down and having hands sanitised and put a mask on is probably the key safest way. Clearly want people to openly disclose their status and tell friends why they're wanting them to transport them there. clearly driving yourself's the easiest, but we recognise other people are going to be driving you, and sitting in the back, as I said, with the windows down is probably the optimum. I think we just need to work through it. Obviously, there have been times when people have taken Ubers and other things. And again, it's a really around minimising the risks in those settings, but also being very transparent about the reason for, you know, you wanting to get travelled. And the Uber drivers may be very unhappy with providing that transport under those circumstances. There's no one perfect solution, but obviously we do. I believe some of the pathology labs also do drop-offs of kits to homes for home collection, and that some people can actually be within walking distance, you know, reasonable walking distance if you've got very minimal disease, where they're not compromised, that can actually walk to various testing kit sites as well. So probably a mix of different strategies. None of them are perfect, but the protection of wearing the surgical mask and making sure you've had really good hand hygiene will actually minimise the risk of anyone else being exposed. And to some extent, we don't want to also put too many barriers for them getting tested. So it's this real juggling act that I know GPs are used to juggling, but there's never a clear-cut answer in some of these cases.
And I think we may be underutilising the home testing and the self-testing and the pathology labs. I must say that I had someone with chest pain that had to be picked up by the ambulance who didn't want to come in. We had to walk them outside and wait while they put on their gear before they'd go anywhere near the patient. So it was very understandable.
As you say, it's the balance between the right advice and pragmatically getting things done. Danielle, your turn.
Yeah, look, on the contact tracing side of things, there's an interesting one here that comes up time to time about who to test and when, and it's about the requirements for the contacts of contacts. So if you've got a definite exposure and then they've seen their family members or friends and things, and whether these sort of secondary contacts are currently required to do anything special, whether they need to self-isolate or not. Presumably if GPs have questions on a particular case, who should they call to get more advice on a specific case? But in general, if you're that secondary kind of contact, a contact of a contact, what do you do?
So if you're a contact of a contact, we're not requesting that you do generally anything, but I've got to say that what we're actually even just thinking about now is just being very, even in our contact tracing, maybe having some element of when they were exposed and whether there's any risk, particularly if they're household-like contacts and the sensitive ones like school kids or aged care workers, and potentially providing some additional advice to those household contacts of contacts. So that's something we're thinking about. And that's because sometimes when it isn't a neat outbreak or there's some delay, those contacts may be incubating the disease, have actually become infectious and passed it on. And if those people go to school, they may have already been infectious. So to some extent, I think we're learning. And at the moment, but generally, contacts of contacts do not need to be isolated. But what I'm talking about is as we're responding to these outbreaks, we are probably erring on the side of caution. And we actually just came from a discussion with the public health units about would there be contacts of contacts who are very high risk, where we might actually recommend something else for those contacts of contacts. But generally that will be public health assessing that. And as I said, you can see the rationale for that is if we think the transmission's occurred and they've been exposed long enough to get symptoms, we don't want them going into particularly the contacts of the contacts go into particularly vulnerable settings. So we're just working through how we incorporate that. But as a general rule, contacts of contacts are okay. Nothing is ever absolute when it comes to COVID-19.
Nothing's absolute in medicine though. So general practice should hopefully be even more au fait with uncertainty than some of our other specialty colleagues. But
and mind you, it is a space that changes every day, doesn't it? I mean, I think that's been the challenge for us is that you think you're on top of it and then it changes and the evidence emerges. I mean, I remember right at the very beginning, Kerry, when it was just in Wuhan and we had the meeting with Chinese Medical Doctors Association, and we were talking about, were there any people with no symptoms who could have the infection? And at that time, the advice was it was highly unlikely because that was SARS. And yet, of course, it's turned out that that's not the case. And so it's sort of like that thing of, well, this is an emergent picture, and more cases are sort of showing that there's variations to a theme just to keep us all on our toes.
And I suppose just to let you know that, and maybe if I just take you through a couple of the scenarios and why our advice may change, because I think that's also very confusing to GPs, and we are going to try and improve the information on our website to sort of describe different settings. So, for instance, when we first were dealing with the Crossroads cluster, so we had this situation where there was an obstetric registrar tested a woman who was actually pregnant, who presented with back pain and fever, tested her and found her to be COVID positive, and then another person in Nepean Blue Mountains presented and got a COVID test. And when we looked, we're now at the stage where before we used to just worry about who they passed it on to. Now we're actually looking at who could have given it to them to see where there could be another source of infection, a chain of infection. So for both of those, we looked back 14 days because that's the incubation period for the disease, and found out they were both at the Crossroads on the same day, on the 3rd of July. Now, the probability of two random events like that was very unusual. These people didn't know each other. And so when we went into the Crossroads, we didn't actually know what we were going to find. You know, was there just these two transmission events, or was there going to be many more cases? And we actually took a very wide, we called out for the testing. We looked at the time, and then what we did is to change our advice as we found new cases, as we found additional infectious people. And so I know it's very confusing, but there is method behind our madness. So when we do change the advice, it's usually because we've found another person there, or we've had another transmission event on a different day. And so we've often treated people perhaps as casual contacts and just said, come forward and get testing. And then if we've found disease, we might make everyone close contacts and ask them to self-isolate. So the advice can change because we find new pieces of information. But what we know is, particularly when we're dealing with younger age groups, and I define that sort of as that 18 to 40-year-old age group, that's probably, we're all young, but that sort of age group, people are presenting and not reporting significant symptoms. And so they're still going to the gym. They're still, when you question them, when you forensically question them, they'll say, I had a bit of a headache or a bit of a this, but they're not perceiving themselves to be unwell. So when you say, come forward if you've got symptoms, they're not putting themselves in that box. And so for that reason, we've really, and because we want to suppress this, I mean, our aim now is no community transmission. So we want to stomp this out. So therefore we have to cast a really large net, get high rates of testing, and find some of these individuals. And that's been very effective because we've found some really infectious individuals who would have managed to transmit it to multiple, who have transmitted it to multiple people. And it would have been scary if it had gone for the next stage. And just to be clear, when we say there was this number associated with the Crossroads cluster, there's relatively smaller number that were infected on the day, and we think there were probably between one. So how we think it happened was there was someone came up from Melbourne in a workplace, transmission in a workplace. There were probably between 1 and 3 people on the 3rd of July that were positive in that venue at the Crossroads Hotel. that then spread it to a number of others. And then what you actually see is secondary, tertiary and quaternary cases. And what we've actually been able to see is quite short, relatively short incubation periods that play out. I think you can see by the numbers how if we hadn't detected that, we would have ended up with that number probably fivefold, because it would have been an unmitigated, and those chains of transmission would have continued and amplified. So that gives you a concept that your critical role in finding any one case, because we know we won't find ever all of the cases, but at this moment we really need high rates of testing so we can block as many chains of transmission and get some behaviour change for the population. We need to up the mask wearing, we need to up the behaviour change, social distancing and the hygiene, not going out and about, limiting family gatherings, not being as social, not being as mobile. We don't actually want people going from here to rural regional at this time, because we think we haven't got many signals coming from rural regional. So if we can get those changes in behaviour, then hopefully we can get the reproductive rate, the R effective, beneath 1, and see it basically extinguish itself. So that's the aim. And you as GPs play an incredible part of that. So I can't urge you enough. Test at the moment, and help us squash it.
And so, Kerry, that's really nice to hear that you've actually got that even in your thoughts. One of the questions was saying, how are we going with reagents and swabbing resources at the moment? Do we have enough to ramp up?
We do have enough. Obviously, we're very watchful of supply, and swabs has been variable and we have challenges. But of any of the states, Victoria and New South Wales needs to test, have high rates of testing. So for me, we have, I think we've been having high rates of testing. It's amazing how the poor weather and probably a combination of Sunday, we saw lower rates of testing. I'll see the data shortly for the testing results today. But I remembered the time when we thought getting 8,000 a day was good, and now we're not sort of satisfied until we're getting well over 15,000, and on other days we've got well over 25,000. So I think it's critical. Also, what's interesting is some of the latest data, and our EPI report we've circulated to you, it shows that sometimes we can change behaviour, and it's so pleasing because it looks like people are coming forward a little bit sooner and they're having symptoms for a less time before getting a test. So again, that's really amazing. So again, messaging that, if patients have got symptoms, don't wait till day 3 of their illness or day 4, come towards, day 2, day 1 or day 2. Because again, you can imagine if they've been day 4, they've had 4 days of infecting someone else, their contacts will have already potentially, if they're exposed on day 1, by the time we have a bit of lab delay, not lab delay, but just lab processing, you can see where you're 6 days short if they come forward on day 4. And you're that far behind the 8 ball in trying to contact trace and lock it down.
Sorry, with the all of the testing that we've done, I'm interested in what the rates of flu remain as. We know that we saw some really stunningly low rates of influenza in the beginning. I've heard that we've had some high-ish rates of rhinovirus. Is there any sort of commentary that you can give us about what the other respiratory viruses are that are coming through, and in terms of rates in comparison to what you would have expected in a normal year?
So the flu levels are actually quite low as far as I know. I haven't been briefed before this, but certainly no one's raised an issue that flu's going up. Interestingly, I think Dominic was on the last video conference with us, and his view of the rhinovirus is that we have to be careful about comparisons with previous rates, because we never would have tested people with such minimal symptoms in the past. And so he was saying that the rhinovirus reflects the fact that people are getting with minimum symptoms are getting tested, and that's more likely to be rhinovirus. And so that's an interesting reflection. So I had thought it might mean that our behaviours were slipping, but I think, you know, on reflection, Dominic's made a really valid point that we're probably testing a group that we would have normally not even tested.
And I think it's worth reiterating, there's a number of questions coming up here too about what's the rationale of COVID-19 testing for children in childcare who have cold symptoms and that then need clearance. Why are we testing for them? But I think we do need to emphasise the need to be testing anyone with any cold symptoms, even if it's children in childcare.
That's correct. And to some extent, we know that when school's back, students are sent home if they've got symptoms. And whilst children, you know, haven't been represented overly in our data compared to what we would expect for things like flu, it doesn't mean that children can't get the disease. So we just need to be clear about that. Their consequences are much less, and certainly the under 10s seem to have a much less predisposition to acquiring COVID. But within households, they can acquire it. So we still need to be testing children. And what we want to do is see testing across the age groups.
Kerry, you mentioned before the importance, and I think we've talked a lot about the importance of people not being complacent at the moment, and that Sydney side, you know, Metro New South Wales in particular really needs to take this seriously and adjust behaviour around attending venues and, as you said, not travelling outside of metro areas. How are you finding that that's going when it's just a recommendation rather than a restriction? We're hearing lots of pushback, I think, from patients and just the media and things about how important is it really to do these things? Why doesn't the government just lock down if the health advice is to lock down? And how enforceable are these ideas?
I think you have to take the community along with you and explain the community. So regardless of the lockdown in Victoria, there's still challenges with some, the community adhering to them. So I think we need lots of strategies. You know, obviously the instruments are important, but I've got to say that our public health messaging and your messaging as GPs, we shouldn't underestimate the power of it. It's been really amazing. We sent a letter out to aged care facilities and just recommended something, and it was interesting. We had a near miss in an aged care facility, and that was because they heeded the advice. So I think, and I've noticed that there has been some of the data shows that there has been a shift in behaviour. So the modelling, the micro and macro distancing modelling, has shown that we have seen some behaviour change in New South Wales. That's stronger than what we've seen in other states and territories apart from Victoria, and you'd expect that because Victoria's in a lockdown. So I think we shouldn't underestimate public messaging, and we don't have to change everyone, but as long as we can get the majority, and you know, where it is critical, I think, you know, having it legislated as well helps us, but we should use all the tools at any point in time, and, you know, GPs advocating and you know, continuing to message these important public health measures will help. And sustaining it's going to be hard. I mean, this is one of the challenges for us. We're used to giving advice that impacts for the short period, but I mean, we're going to be dealing with this probably for another 12 months. And so we're going to have to battle fatigue in our patients and fatigue in the community, fatigue in business. And we also do need to manage the mental health well-being, employment. You know, it's complex. But my focus now is stomping out any virus transmission that could be there. That's my aim, and I can only do that with everyone working together, including the GPs. And you are so important over the next. You're always important, but for COVID, this is probably one of the most critical period. This is the most critical period in our response.
So Kerry, it's been interesting because the first time we went through this with the initial rise, people were much more attentive and were much more compliant, I guess, and appeared a bit more motivated. And now we're sort of going through this second rise. Have you noticed a difference in sort of behaviour between those two sort of waves or two rises, if you like?
I think that people, it's hitting a different age group and demographic. And so I think if you reflect, the first wave was largely returning overseas travellers, or it got seeded into households and some community transmission in those suburbs. And so I think there are different challenges confronting Victoria and New South Wales in bringing this under control. We're seeing it in a younger age group, and we're seeing transmission events in venues that perhaps weren't the case earlier on because of the age and demographic. So I think it is a very different response, and I suppose I'm not best placed to understand the behaviours of the public and the way they respond to the narrative and fatigue, but I think we know that that does play into all of our public health messaging, and what we've got to do is bring the community on a journey with us and use good social media and social marketing, key leaders like yourself, work across cultural and linguistically diverse communities. This is going to have to be very much of a team effort over the next 12 months.
Kerry, there's a really great question here. I think we've all been watching Victoria knowing that it could easily have been us or may still be. And the question is whether what we've learned from the approach to the outbreak response so far in Victoria that GPs should know about now. It's sort of questions around their swabbing options. Do they have big long queues, or have they found a way of managing high testing rates? And how have GPs been involved in their response as far as you know? What lessons can we learn?
So I suppose some of the lessons learnt would be the insidious nature of the disease, how in some communities it can spread and not declare its hand. So that's why GPs working in communities where health-seeking behaviour isn't perhaps as strong, working with vulnerable groups, working in particular communities, we need that high vigilance. So I think that's probably a key lesson. Is to really be focused to make sure that you're getting testing across the board. Obviously, symptomatic testing is going to be of higher yield. So generally, whilst we do asymptomatic testing associated with outbreaks, just for the reasons I articulated earlier, a whole lot of asymptomatic testing's not going to be useful in a non-outbreak setting, and waste resources and waste services that could be better redirected. I think that we've learned about vulnerable workplaces, so aged care and how we've got to keep the disease out of aged care. I think we've learned also about vulnerable industry sectors, and they're things like meat processing centres, logistics centres. They've been really important because when you have an outbreak in those settings, they can actually compromise the food supply. The big logistics centres got taken out and impacted in Victoria, and that required an emergency management response to ensure that food kept flowing. Victoria ultimately supplied the food to all of Tasmania. So we can't underestimate the importance of some of these critical industries that are also very much at risk if COVID gets into them. So we've been doing some work with the meat processing plants, and they employ something like 1,500 workers, and there's also significant animal welfare issues if they close down or stop their production. So some of our public health units who have these meat processing plants in their districts have done some work with Safe Work New South Wales, and also the Department of Primary Industries, to look at how we can even enhance their COVID safety plans, the PPE they wear, and what would be our response if there's community transmission in the vicinity or the area of these meat processing plants, to keep it out. So that's the conversation we've just had. And also logistics centres, because if you take down a logistics centre, then that's really the food distribution hub. And it's interesting, we have got lots of food in New South Wales and food Australia-wide, but it's all just-in-time ordering. So whilst there's plenty of food, it's just also about just, you know, as everyone moves to just-in-time, everything has to keep moving to get that food supply chain working. I think we've also learned about the importance of having people isolate for a test, and I know, so waiting for the test result, and I think, you know, making those test results come back in a quicker time frame is really important, but really re-emphasising that people need to isolate the test result, and that's really important. There's probably been contact tracing and the importance of contact tracing. And I think one of the strengths in New South Wales is our district public health units, who can also tap in more closely with local health districts. Like, I've got to say, we heard about the cluster in the association with the 3rd of July at about 2 o'clock in the afternoon on a Friday. We had a pop-up clinic at the actual Crossroads Hotel by 5 o'clock. So I think that, and, you know, clearly we need to, in our planning, look at how GPs can be integrated better in our response. And I know Charlotte and Penny have raised that with me about how we can better integrate GPs. But I think that ability to have those teams rapidly stood up, and the testing, and also our pathology, our centralised pathology, which is able to decant across multiple labs, so that you don't get a roadblock when you get a big increase in testing in one geographical area. That's probably been another learning. And I think acknowledging and working closely with the private sector laboratories, that's been another, you know, another learning. There's probably too many learnings, but we're continuing to learn in COVID. There's so many learnings.
Never too many learnings, Kerry, never too many learnings. And I think the challenge is being able to sort of keep fresh about it. And it's good for our sort of thinking and the way that we respond. But certainly from where I sit, it's been great watching New South Wales Health under your guidance work and get this sort of flexible model of adjusting to it. It's been great. Though my big challenge is still getting the results to the GP. And I know there's a few comments in the questions about that too. And, you know, I mean, you know, I've been nagging you constantly about the need to get this improved, and looking at the My Health records and looking at how we do it. And there just seems to continue to be sort of issues around it. I mean, I know myself, I've got a young fellow in who goes to respite care who was tested, and, you know, the mother, they don't speak English, and the mother's been nagging me to try and get the result, and it was really difficult. And, you know, they still haven't sent me officially a result, but to be able to get a result to the respite care so it could go back was so important for that family to be able to hold together. Let me tell you, you know, he's hard work.
And look, raise those issues with me, and so I can raise them with pathology. I think there's been some pieces of work done around trying to get people on the SMS text message system. I think you suggested we do signage, and I think that's a really good idea about making sure that you put your GP down on the forms. So we're really open to some ideas. Again, there's not going to be one silver bullet, but I think it gives us reassurance if the GP's involved and knows. So that's, I think we've got it aligned with our aims. We just got to do some more work at trying to make it happen more of the time than it does currently.
My hope is that it flows across the system, can I say, Kerry, and so that the GP then starts to be identified better everywhere. So the whole, into accident emergency, all test results, etc. So that we improve the culture of understanding that that really patients do have GPs. The number of times I've been told, most of the patients I see don't have a GP. Like, well.
And you've raised it's how the question's asked, and I think we need to address that. The other thing that is a lesson learned, I think, is the fact that it would be great if we were on an interoperable pathology system across the privates and the publics, because that would just make uploading and communicating and decanting. So there's also some infrastructure and maybe some visionary stuff that needs to come out of this response as well.
But the computer says no.
I'm sorry to interrupt here, guys, but it's 8 o'clock. We're going to have to wind up. And look, and again, I'll hand over to Bethany to thank everybody, but it's been really good having Kerry and Danielle here.
Thank you. Thank you so much. Unfortunately, that hour does go very quickly, and it's all that we've got time for tonight. We have had a number of questions that have come in, and I'm so sorry that we didn't get around to them all, but we do have another webinar that is scheduled for next Monday on the 3rd of August. So hopefully we can get some more of those questions answered for you. So I'll just take a moment to thank our panel. Thank you to Kerry, Danielle, Penny and Charlotte for this evening. Such an informative session. And thanks to everyone online. Stay safe and have a good evening. Good night.
Thank you all. Good night.